And Ilaria is going to start with the classical assessment of posterior uveitis.
Thank you. Thank you. Okay, thank you. Okay, so during the last few years, we have witnessed the increasing use of technology, including multimodal imaging, investigation, and laboratory tests. And the risk is that some of the ophthalmologists may be prone to take decisions, make diagnoses, or treat also the patient just on the base on single OCT findings, or maybe on the single positivity of the laboratory test without even examining the patient. So what I would like to show you during this presentation is that in most posterior uveitis, you can think of a diagnosis and differential only with a history and examination. So what are the findings on posterior uveitis? So we have retinitis, choroiditis, vasculitis, but if it's not retinitis or choroiditis, it is uveitis or is something else that is not uveitis and is confused with uveitis. But also, make sure not to confuse infective and non-infective uveitis, but also make sure not to mismasquerade. So it might seem all very complicated, but actually is not. So the key to make the diagnosis is pattern recognition, okay? So what you have to do is looking at the phenotype and try to fit the diagnosis into clinical entities. So first of all, make sure not to confuse retinitis with choroiditis. So if you look at these pictures here on your left, you see that you have you see that you have a whitish area of retinitis. You have vitreosis, vitreitis, and if you pay attention at the vessel, you see that the vessels are obscured by the lesion. And if you look at the picture on your here, right, okay, you can see that the lesion is totally different. So you see it's something subretinal. You can see that you have not the same amount of vitreitis that you have in the retinitis on your left. And if you look carefully also at the vessel, you can see that the vessels are running over the lesion with very defined margin. And then obviously, if you use multimodal imaging, this will help you. So you can see on the OCT on your left, it's confirming that you have a retinitis, but also you see that you have choroidal involvement, so you are dealing with a retinochoroiditis, while on the other side, you see that the pathology is starting at the level of the choroid and then is involving the retina in a secondary way, so you are dealing with a chorioretinitis. When you see retinitis, the chance of being infective are quite high, okay? So we are not speaking about rare things here. Retinitis can be focal or can be diffuse. When you have a focal retinitis, the most common cause of infective focal retinitis is toxo, okay? While on the other side, you see a diffuse retinitis, and what you don't have to miss in diffuse retinitis is viral retinitis. So speaking about toxo, you can see that the clinical features are quite characteristic. You have this typical whitish lesion, headlight in the fog, you have vitreitis, you have vascular involvement, and then obviously, if you have a pigmented scar very close to an active lesion, the diagnosis is even easier. Let's move now to diffuse retinitis. So you can see 4 different cases of acute retinal necrosis. This is what you don't have to miss. This is sight-threatening condition, and the clinical picture is quite characteristic. The diagnosis is a clinical diagnosis. So you have these multiple patches of peripheral retinitis in a circumferential way with vitreitis and with vascular involvement. However, we have also different phenotype for viral. So these are 2 classic phenotypes for CMV retinitis. This is usually happen in severely immunocompromised patients. So you have the first phenotypes on your left here. You see this whitish area. Sorry, go back. Okay, you have this whitish area of retinitis with some hemorrhages, you have satellite lesion and edema. While on your right, you can see the second typical phenotype, which is the granular or indolent phenotype, typically characterized by this peripheral granular lesion with very few or no hemorrhages. But when you have retinitis also, you have to make sure to think of syphilis, which is the great imitator. So what is characteristic of syphilis from the clinical point of view are these yellowish creamy lesion overlying the area of retinitis that you can see on the OCT as these hyperreflective dots overlying the retina. You can see here other example. And also what you have to pay attention is the appearance of the retinitis. So if you look on your right, this syphilitic retinitis has this ground glass appearance, which is quite different from the deep yellowish appearance of the retinitis that you have in acute retinal necrosis or toxo-retinochoroiditis. But is it retinitis always infective? So far we have seen causes of infectious retinitis, but the answer is no. So retinitis is not always infective. So if you take a look at these two pictures, this is the same eye of the same patient, 6 weeks apart. So we have different inflammatory episodes, okay? So what we have here, take a look at the clinical features. So we have diffuse vitreitis, quite severe vitreitis in the second episode. We have multiple retinal infiltrate, whitish. You can see they are distributed in any location and any number. And then if you look carefully at the picture on your left, you can see also vascular occlusion with some retinal hemorrhage. And what is important to see also, that this retinal infiltrate just disappear without leaving any chorioretinal scarring. So all these pictures, putting together all these clinical features, these are quite suggestive of Behçet. So the retinal infiltrate, superficial retinal infiltrate, are quite characteristic for Behçet. You can see here on the OCT scan is superficial in the retina. Unfortunately, sometimes this retinal infiltrate can be deeper in the retina, and this makes it a bit more difficult to differentiate from the infective retinal infiltrate. So we have seen the retina, we are moving now deeper, and we're going into the clinical feature of the choroid. So inflammation of the choroid can be divided into choriocapillaritis and stromal choroiditis. And choriocapillaritis can be primary choriocapillaritis like PIC, AMPI, serpiginous, or secondary choriocapillaritis, for example, tuberculous serpiginous like choroiditis or the syphilitic placoid. And then we have the stromal choroiditis. So once again, what I want to show you, these are all pictures of uveitis that are due to choroidal inflammation, choroidal involvement. And once again, you can see that all these phenotypes are quite different from each other. So the key here, again, is pattern recognition, is fitting the diagnosis into clinical entity. So let's start with the choriocapillaritis. So idiopathic multifocal choroiditis, we have PIC and multifocal choroiditis. The two conditions are differentiated based on the location of the lesion. You can see on your right, top right, multifocal choroiditis, you can have lesion also in the periphery of the retina, while top left you have PIC. Usually the lesions are confined to the posterior pole. In PIC, usually you don't have intraocular inflammation, while you can have inflammation in multifocal choroiditis. These conditions are characterized by these multiple atrophic chorioretinal scarring, and they can be complicated quite frequently by CMV. So this is a case of PIC. You see here typical location of the lesion at the posterior pole. In this case, you will need multimodal imaging, you will need autofluorescence and OCT, also to make sure you are not missing any active lesion. So you see here on the top con OCT two RP elevation, and these are suggestive of active inflammatory lesion. Again, another case of PIC. In this case, make sure not to confuse active inflammation with complication. So if you look at the color picture, you see you have two very small yellowish lesions temporal to the fovea. And when you perform an OCT scan on the lesion, you can see that there is an RP elevation, and this is quite suggestive, again, of active inflammatory lesion. However, if you look carefully, there is another more fluffy lesion nasally to the fovea, and when you run an OCT scan over it, you see that this is not an inflammatory lesion, but this is a CNV. So make sure not to confuse the two. AMPI. You see here AMPI, totally different phenotype, typical creamy yellowish placoid lesion, usually located at the posterior pole. Even here, obviously, multimodal images is helping you, especially during the active and healing phase. And then you can see on the imaging at the bottom that AMPI usually heal leaving chorioretinal scarring. And these pictures is totally different from the picture of another primary choriocapillaritis, which is serpiginous choroiditis. So if you look at the picture on the top right, you see the lesion classically start in the peripapillary area, and then they progress in a serpiginous, serpentine way, okay? You can see here you have lesion with different stage of healing, and also you can easily recognize the active lesion that are usually occur at the edge of the previous chorioretinal scarring. So this disease is usually bilateral, is very chronic and aggressive, so patient need immunosuppression. But before immunosuppressing this patient, make sure that you ask for a quantiferon test and you rule out TB. Because there is another condition, which is a secondary inflammatory choriocapillaritis that can be associated with tuberculosis, and this is the TB serpiginous-like multifocal choroiditis. So the two conditions can seem quite similar, but actually they are not. So let's have a look together. So first of all, serpiginous-like choroiditis, the TB one, is usually unilateral, the other one is usually bilateral. Then you can see here on your left, the lesion usually starts at the level of the macula with peripapillary sparing, okay? And then in the TB one, it's usually multifocal, is not contiguous, and then you can have intraocular inflammation that is usually absent in the serpiginous choroiditis. Let's go deeper now, and we go to the stromal choroiditis. So we have the primary stromal choroiditis, where the inflammation target the stroma, okay? So we have VKH, we have birdshot, and then we have the secondary stromal choroiditis. This means that the stroma of the choroid is basically the location of the random inflammation from a systemic disease, namely TB or sarcoid. So let's take a look at this clinical picture. We have bilateral involvement. We have something going on here at the level, look like subretinal, and look like multiple pockets of subretinal fluid. So when you see these pictures, what are you seeing is already the tip of the iceberg, because this means that the inflammation from the stroma of the choroid has been already spreading around to the surrounding structure, and these are namely the retina, the optic disc, and then sometimes also ciliary body and anterior chamber. So we are dealing here with the acute initial onset VKH. You can see on the ICG diffuse stromal choroiditis with multiple hypofluorescence dot. You can see your retinal detachment on the IOCT, but you can see that clinically you can see your multiple subretinal fluid, retinal detachment. Another primary stromal choroiditis is birdshot. So when you see the picture, the clinical phenotype on the top left, this means that the disease has been already going on for quite a while. The disease is chronic and has been not treated uncontrolled. Why? Because you are seeing this typical rice-shaped cream color lesion that they are known as birdshot lesion. So this means that the disease has been going on for a while, and this has already given the typical depigmentation of the fundus. Keep in mind that these depigmented lesions, they are not corresponding to the active lesion that you are seeing on the ICG. And we will see better on these pictures. So why we want to treat birdshot at the early stage? So this is another case of birdshot. You see the fundus is totally normal. Patient complain of floaters. When you do FFA-ICG, you have diffuse vascular leakage, you have diffuse choroiditis, but you see you have to treat this patient before the lesion develop, okay? So the birdshot lesion are helping you in the diagnosis, but they are not a criteria that is necessary, required for your diagnosis, because you want to treat the disease before. Okay, secondary stromal choroiditis, meaning basically involvement of the choroid secondary to TB or sarcoid, okay? So usually it's granuloma. So when you have a granuloma, you have to differentiate between TB or sarcoid. And there are some clues, some tips to do this. So in this picture, in this slide here, you see all cases of TB granuloma. They are usually solitary. They are usually very deep yellow in color, lobulated in size. They are usually bigger than the sarcoid one. And pay attention at the top, you see they are usually vascularized, so they can have retinal hemorrhage. And you can see here the differentiation with the sarcoid granuloma. They are usually smaller, multiple, just randomly located at the posterior pole, and you can see that they are dull in yellow, so they are quite different. And this is seen better on the OCT scan. You can see granuloma, TB granuloma on your left, with full thickness on the OCT scan with secondary retinal involvement, while the sarcoid granuloma are usually smaller, not full thickness, and they are not associated with secondary retinal involvement. Okay, so we have seen retinitis, we have seen choroiditis. Just briefly, retinal vasculitis. What is important in retinal vasculitis? So clinical characterization is phlebitis, is arteritis, or is capillaritis. And then obviously it's diffuse or focal. If there is any choroiditis or retinitis, this is helping you in the diagnosis, and then obviously make sure to understand if it's occlusive or not. So let's take a look at this case. We have left eye, mainly, clinically, with a few retinal infiltrate, and we have in vasculitis, look like occlusive vasculitis with retinal hemorrhage. And when you perform an FFA, you can see here area of capillary non-perfusion. So this is a peripheral occlusive periphlebitis in Bechet. What you have to pay attention here, that even if clinically it looks like in the right eye there is nothing going on, the eye is quiet, if you do an FFA, you can see subclinical inflammation, leakage. So in Bechet, always do an FFA because you can detect subclinical inflammation. Another case of another disease associated with the peripheral occlusive periphlebitis is TB. You see here area capillary non-perfusion, retinal hemorrhage, and this is totally different from the sarcoid. Sarcoid is usually segmental periphlebitis and is usually not associated with occlusion, with occlusive vasculitis. Okay. When you have choroiditis patches, this is usually quite suggestive of TB, so patches of choroiditis along the vessel. And obviously, when you have other area of retinitis, this is helping you. So in the first two pictures, you have acute retinal necrosis with vasculitis. In the other picture, you have a focus of retinitis with two pigmented chorioretinal scar and vasculitis, and this is toxo. So far we have seen clinical features of uveitis, but what if it's not uveitis and it's something else that is confused with uveitis? So this is a patient, a child, 12-year-old, male, sent to our attention for vasculitis. But when you see this picture, you see that there is something else going on. So you can see tortuosity of the vessel, rod spot, retinal, subretinal infiltrate. So it looks a bit weird just for an inflammatory vasculitis. So we asked for a white count. It was quite raised. And then the patient ended up with a diagnosis of chronic myeloid leukemia. And this is our patient after 4 weeks after treatment with imatinib. So make sure not to miss masquerade. This is another case, patient referred to us for choroiditis. However, when we performed an OCT scan, we saw that there was something in the subretinal space. So subretinal space is quite an unusual location, I would say, for uveitis. So even in this case, make sure you don't miss masquerade. And this is a patient that was diagnosed with lymphoma. So also, just to conclude, make sure not to confuse non-uveitis with uveitis, and in particular with VKH. Why? Because if you give steroid in CSR, the situation can get quite worse, and I would say quite a lot worse. So make sure not to confuse non-uveitis with uveitis. So just to conclude, what I wanted to show you, that phenotype is important, that pattern recognition is the key to make the diagnosis. So you have to fit the diagnosis into clinical entities, to think of a diagnosis, think of differential, and then obviously then you are going to confirm your diagnosis with targeted investigation, and then you treat your patient. Thank you for your attention.
Thank you. Thank you. Oops, doesn't work. Yeah. Thank you very much, Lara, for the beautiful presentation. We're going to have the discussion after the next speaker. Two technical things. Number one, we got more spots here. I see a lot of people standing in the back, so you can come forward and find some spots here. And second thing is that Professor Pavesio says hi to everyone. Has